Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC, and we have an interesting paper in press that deals with the value of CT scanning for calcium in asymptomatic individuals at intermediate risk. Obviously a question that comes up over and over again. And here to discuss that with us is the senior author of the paper, Dr. Mirjam Hoenink, and she is professor of epidemiology and radiology at Erasmus University in Rotterdam and an adjunct at Harvard University, and also one of her research associates, Dr. Bob van Kempen, also from Erasmus University. And in this study, what they specifically examined was the comparative effectiveness and cost effectiveness of screening for coronary calcium as opposed to standard therapy or other strategies such as just applying statin therapy for everyone at intermediate risk. And their data would suggest while CT calcium scanning is really a value in men, it may not be cost effective in women. So Dr. Hoenink, tell us just a bit about the structure of your study.
Well, the study was really performed as a decision model and a simulation study. So we used the Rotterdam study data, and we used several meta-analyses from the literature, and we combined and integrated this data into one whole to come up with a model that replicates, first of all, the natural history as we see it in the Rotterdam study, to look at what would happen if current guidelines were implemented properly, what would happen if you would just prescribe statin therapy to everyone, and what would happen if you use CT screening. So it's a simulation study, a hypothetical study to compare the natural history, as it were, to these other strategies.
So in this strategy, it requires some assumptions, for instance, about the cost of medication and the cost of various complications that might occur. Now, what kind of data did you use for that? Was that American data or Dutch data? Is there any difference?
Well, the cost data, we retrieved that from American data. The probabilities we retrieved partly from American data, partly from the literature, and partly from Dutch data. And we feel that the Dutch data from the Rotterdam study is very likely to be applicable to the United States. The cost data, clearly, we needed the American data to make it applicable to the United States.
So, Mr. Van Kempen, why is it that CT scanning for calcium is more effective in men than women?
Well, first of all, it's about individuals who have at baseline an intermediate risk for coronary heart disease. And that means that women have less favorable risk factor profiles. So on average, their LDL cholesterol levels are a little bit higher, as is their systolic blood pressure. So at baseline, they are in more need of treatment than men are. Secondly, if you look at the reclassification, more women are reclassified to the low risk group as compared to men. And if they are reclassified, their observed risk in this low risk group is also higher than in men. It's close to 8%, which is close to the threshold. So there's a foregone benefit because you don't treat these women in the low risk group. If they are reclassified to the high risk group, then it appears that it happens less often than in men, and also their risk in the high risk category is lower in high risk category in women than in men. So there's less to be gained as well in this high risk category. On top of that, aspirin is prescribed in men, whereas not in women. So also the effectiveness of the treatment in the high risk group, where you have the effectiveness part, is less than in men. So in total, that shifts the balance to a less favorable position of CT scanning in women compared to men.
Well, what we liked about this paper especially was a very rational approach that in the intermediate risk group, which is the group where reclassification would obviously make the most difference, that application of CT scanning for calcification really could be of value, especially in men. And I think that this kind of analysis gives us the basis for how to apply this technology in our patients. Thanks very much for being with us. For Inside JACC, I'm Tony DeMaria.